Assalamualaikum. Can you hear me?
Waalaikumsalam. Yes, we can hear you, Doctor.
Insyaallah kita bagaimana kita Al-Fatihah. Okay. Sorry all, need to postpone 1 hour because actually the meeting pun has not finished, but I just go on. So we proceed today with 3 topic of cardiology kan, the congenital heart disease. The first one about the cyanotic, second one cyanotic ya. Yang third apa ya? Saya lupa ya.
Obstruction outflow. The first one.
Okay, alright lah. So let's proceed with the presentation. Presenter ni tak apa nak submit to me ya di slides ya.
Sorry,
so
Doctor. I'll send it to you after. Is that okay?
Alright, sure.
Okay.
Start now. Okay, Assalamualaikum warahmatullahi wabarakatuh. Bismillahirrahmanirrahim. Okay, for today's seminar, congenital heart disease, I, as the first presenter, will talk about coarctation of aorta and pulmonary stenosis. So, congenital heart defects can be divided into 3 pathophysiologic groups, which are left to right shunts, right to left shunts, and also the third is obstructive stenotic lesion. Okay, for the second presenter, we will talk about stenotic congenital heart disease, which are the VSD, PDA, and ASD. Will be presented by Sister Alisa, and the last presenter will talk about cyanotic heart disease, TOF and TGA. We'll present about by Brother Emir. Okay, the outline for today's presentation is definition, epidemiology, etiology, pathophysiology, clinical features, investigation, management, and also prognosis. Okay, for the definition of pulmonary stenosis, pulmonary stenosis means a clinical condition when the pulmonary valve leaflets are partly fused together, giving a restrictive exit from the right ventricle. It is characterized by obstruction to blood flow from the right ventricle to the pulmonary artery. Pulmonary stenosis accounts for approximately and can be in form of valvular, subvalvular, and also supravalvular in nature. There are several risk factors for pulmonary stenosis, including prematurity, family history, genetic syndrome, and extracardiac abnormalities, and also maternal factors. Next is pathophysiology. As we know, the normal function, the pulmonary valve consists of 3 thin and pliable leaflets, which opens easily as the right ventricle ejects blood to the lung for oxygenation. It functions as a one-way door, allowing blood to pulmonary artery. The problem with pulmonary stenosis, it makes it harder for the leaflet to open, and therefore causing disruption to normal blood flow. The pathophysiology, obstruction to the outflow from the right ventricle to the pulmonary artery, which will lead to increase in right ventricular systolic pressure, and also stretch to the wall of ventricular, and eventually lead to right ventricular hypertrophy. Next is the clinical features. The symptom depends on the degree of the obstruction. Patient with mild pulmonary stenosis is asymptomatic. Most of them are asymptomatic. The patient with moderate to severe stenosis results in exertional dyspnea and easy fatigability. And newborns with more severe stenosis may be more symptomatic and even cyanotic because of right to left shunts at the atrial level. It is called it dark dependent pulmonary circulation. The physical signs include as ejection systolic murmur, um, ejection systolic murmur at the second intercostal space, which radiate to the back. And this ejection systolic murmur are best heard at the upper left sternal edge. And also we can also appreciate ejection click at the upper sternal edge. And trill also may be present at the upper left sternal edge. Next, for investigation part, and for investigation from the history alone, we can appreciate the degree of the obstruction present. And newborn mostly poor feeding, tachypnea, and also cyanosis. And for the first picture is chest X-ray. The heart size is usually normal on chest X-ray, although we can see the dilatation of the main pulmonary artery may be seen. And from ECG, there is evidence of right ventricular hypertrophy. As you can see, the upright T wave in V1 and also right axis deviation. And the fourth investigation is echocardiogram. From the echocardiography, we can assess the site of the stenosis, the degree of the hypertrophy, and also the morphology of the valve. Next, proceed to the management part. One of the most common procedures for pulmonary stenosis is balloon dilatation. It consists of is involved of using a balloon at the tip of a catheter, uh, which we place across the valve and is inflated to open up the narrow valve. Once the catheter is placed in the valve, the balloon is inflated until the valve are open. Once the valve is open, the balloon itself will be deflated and the catheter will be removed. However, for newborn with more severe symptoms, more severe condition, they require early intervention to restore the blood flow to the lungs, either through catheter-based surgery, catheter-based intervention. And the prognosis of this treatment management is generally good. Next, we proceed to the second one, is coarctation of the aorta. So, coarctation of the aorta basically mean narrowing of the aortic lumen. The definition of coarctation of aorta is a clinical condition when the arterial duct tissue and circling the aorta at the point of insertion. Okay, as you can see, there is three types of coarctation of aorta. It is almost always on the juxtaductal position. This is due to the arterial duct tissue that encircling to the aorta just at the point of insertion of the duct. When the ductus arteriosus closes, the aorta also constrict, when the aorta is constrict cause severe obstruction to the left ventricular outflow. The epidemiology and etiology of coarctation of aorta. Coarctation of aorta occurs in about 5% of all congenital heart defects. Male to female ratio 2 to 1. And coarctation of aorta is most common cardiac lesion present in Turner syndrome. The pathophysiology, the proximal part of the coarctation will increase in pressure, which will lead to the left ventricular hypertrophy and also hypertension in the upper body. While in the distal part of the coarctation, uh, this part will become hypoperfuse, which will lead to lower blood pressure and pulse pressure and on the abdominal organs and lower extremities. This malperfusion, for example, to the intestine, will increase the risk to develop sepsis due to enteric organism. Next is for the clinical manifestation. For the clinical manifestation, the symptoms in neonates and infants includes poor feeding, dyspnea, uh, respiratory distress, can also develop shock before the age of 2 weeks, generally 2 weeks of age. The classic symptom are femoral pulses, which are lower. The femoral pulse are generally weaker than and delayed compared to the right radial pulse, the upper extremity. And also the blood pressure in the lower extremities is lower than the upper extremity. In the older children, which present with coarctation of aorta, usually most of them are asymptomatic. There may be history of leg discomfort with exercise, and also decrease or absent lower extremity pulses, and they have hypertension or murmur may be present. The murmur type is systolic. Is the murmur systolic murmur typically are best heard at the left sternal edge, left upper sternal. Next is okay for the pulse rate. For the sign, there are weak or absent peripheral pulses and radiofemoral delay. This is due to bypass in bypass via collateral vessel, and also BP in the upper limb are higher than BP in the lower limbs. And also for the precordium, systolic murmur are over the upper left sternal edge or the back. Sometimes it's radiate to the back. Next part is for the diagnosis, the investigation. From the chest X-ray, for units we can see cardiomegaly and pulmonary congestion. For patient older children, we can appreciate rib notching. I will show you about how is rib notching. Also increase in pulmonary vascular marking and also cardiomegaly. For the ECG, in neonates, there are right ventricular hypertrophy. In older children, however, there are left ventricular hypertrophy. From the last is echocardiogram, from the echocardiogram we can assess the patient's heart condition. We can appreciate the narrow side of the coarctation of the aorta. Next is the rib notching. Okay. This rib notching is rib notch secondary due to dilated intercostal collateral vessel. This development of large collateral intercostal arteries which run under the rib posteriorly and inferiorly to bypass the obstruction, and it will erode the inferior margin of the ribs, resulting in the notching. As you can see, the notch is shaped like a number 3. This 3 sign is with a visible notch in the descending aorta at the site of coarctation. These notching are only seen in long-standing cases and therefore not seen in the infancy. The ribs involved are 4 to 8 ribs. Okay, lastly, next is for the management part. Neonates with severe coarctation of the aorta, the closure of the ductus arteriosus often result in hypoperfusion, acidosis, and rapid deterioration. So, these sick infants require temporary stabilization involving mechanical ventilation, correction of the condition of metabolic acidosis, hypoglycemia, the electrolyte disorder, and second is IV infusion of prostaglandin E1, prostin, mainly to reopen back the ductus arteriosus, to re-establish back the blood flow to the lower extremity mainly before the surgery. For the older infants which present with incidental hypertension of heart murmur, the choice of treatment mainly primary transcatheter balloon angioplasty, or can stent implantation or surgical repair. It depends on the morphology of the coarctation of aorta, and also depends on the age of the patient, age of the presentation of the coarctation of the aorta. Okay, the management of surgical repair, the prognosis of surgical repair for the coarctation of the aorta is generally good. And I think that's it for my part.
Alright, yeah. Siap kan? Okay, so three anomalies kan you discuss kan, the aortic and pulmonary stenosis, and then lagi satu coarctation of aorta.
Yes.
Betul, Najimi?
Yes.
Alright. Hello?
Hello. Yeah.
Okay, yeah. So, discuss. Sorry? Kenapa? Cakap. Repeat lagi Najimi.
Betul lah. Pulmonary stenosis and coarctation of the aorta.
Alright. So, we discuss stenosis first, yeah. Basically similar lah, pulmonary and aortic stenosis tu, yeah. Some but different location only, yeah. So, you need to have good background of anatomical structure of the heart, satu. And then the second one is you must understand the hemodynamic, the flow of the blood, where the blood flows, you know, from where to where. There are two kan, systemic and pulmonary blood flow. Pulmonary is from right ventricle goes to the pulmonary artery, and then lung, pulmonary vein masuk ke left atrium, and then systemic blood flow from left ventricle goes to aorta, to the body, and then back through the right atrium. So sekarang we discuss about the valve, ya. Valve tu, you know there are 4 valves kan. And then the similar apa namanya, timing and timing of the opening and closure is the mitral and tricuspid satu equal to the S1. Is it opening or closure, Najimi? The S1 is sound of mitral and tricuspid valve closure or opening? Najimi, presenter tak jawab.
Mute Najimi.
Tak dengar suara ni. Sorry? Yes? Can you repeat please? Najimi mana Najimi ni? Hilang suara. Oh. Okey lah, tak faham sangat awalnya. Panggil yang lain lah. Everybody can help maybe.
S1 represent the closure of the mitral and also tricuspid valve.
Okay, good, Emir. Yeah. So this is basic. Yeah, you must understand when the mitral and tricuspid valve close, you hear the first heart sound, lep. Yeah. And then when my aortic and pulmonary valve close, you hear second heart sound, dup. Yeah, louder usually, lep dup. Yeah. This is you already know when our previous seminar kan. So this basic hemodynamic sounds you should understand, yeah. So now after you understand this one, S1 and S2, now you learn about this stenosis. Yeah. Stenosis is rigid, yeah. Difficult to open or to close, Najimi.
Hello.
Yeah, apa? Difficult to open or close.
Difficult to open because there is stenosis. It is difficult to open.
Sorry?
The outflow is obstructed.
Good, yeah. When rigid, it's difficult. Ya tahu, saya nak tanya difficult to open or close je dulu. So one by one, because your friend pun, even you pun nanti tak paham sangat. Selalu masa exam nak tanya nomor apa pun tak ada yang tahu. Ini supaya you paham nih. Alright ya. So when it is difficult to open, okay, you hear the murmur due to the turbulence. Alright. So now you go back lagi to the timing tadi. S1 is closing of the tricuspid and mitral. S2 is closing of aortic and pulmonary. So maknanya difficult to open of pulmonary and aortic ni masa ada AS and PS. Is it after S1 or after S2? Tak paham lagi. Senyap kan. Tadi dah present kan. Sudah present pun tak paham lagi. Answer supaya you paham ni. Kalau you tak paham, it is no point lah kita buat seminar dan nanti you buat kelas pun tak paham-paham, masa exam pun tak tahu. Masa jadi dokter pun tak paham. So I repeat, yeah. Can you hear me clearly all? Najimi boleh dengar tak?
Yes.
Very good. Okay. So the stenosis means difficult to open. So when it is difficult to open, Maknanya you hear the murmur of the AS and BS2 after the S1 or after the S2.
After the S2, doctor. The diastolic murmurs occurs between S2 and also S1.
After the S2 is the closure kan.
After
So
S1.
tadi ingat balik, S2 is closure of aortic and pulmonary. Alright. Whereas opening is the aortic and pulmonary valve need to be open during after S1, not after S2. Okay, after S2 kan close kan, S2 is close. When aortic and pulmonary valve need to be open, it is after S1 ya. So masa S2 to S1 tuh masa diastolic phase memang kena tutup. Because kalau keep opening kita sebut regurgitation, nanti darah tuh akan datang balik ke ventricle. Paham tak?
Understood, doctor.
Okay ya, so you understand that the aortic and pulmonary valve need to be open during systolic ya, after S1 close. Not during diastolic, not after S2. Masa F2 kan memang kena close kan. Close the aortic and pulmonary valve, kita sebut diastolic phase, memang kena tutup sentiasa. Sampailah ventricular filling, and then close of the mitral and tricuspid, dia kita start kita sebut systolic phase. Nah, kalau close of the mitral and tricuspid kan systolic phase, maknanya akan ada ventricular contraction. Masa ventricular contraction darah akan lari kemana? Ke arteri kan, PA and aorta. So on that period, the valve need to be open. Okay, paham sekarang?
Yes, doctor.
So the aortic murmur, and then the mainly ejection systolic, early systolic ya. Masa awal-awal tuh, after the mitral and tricuspid valve close, ventricles contraction, and then pump the blood to the artery. So need to open kan valve to aortic and pulmonary. So kalau dia ada stenosis, dia susah nak buka, difficult to open. So kita sebut ejection systolic atau early systolic murmur. Okay, paham? It is very simple, and once you understand this, ingatlah sampai bila-bila. So saya dulu belajar pakai simple je. Nak jadi doktor, spesialis, kardiologis tu just understand this one dah cukup dah. Alright, paham ya? So characteristic of the pulmonary and aortic stenosis will be ejection systolic murmur. Location ya, ikut valve. Aortic valve on the right, upper right. Pulmonary valve on the upper left. Sternal edge. Okay. So itu yang you kena paham ya. Kalau dia pulmonary or aortic valve stenosis, ya karakteristiknya itulah the ejection systolic murmur. Dia simple je itu ya. You understand one. Second thing yang if you want to learn more about the the incident, kenapa dia yang kita kerak tu aortic and pulmonary bukan tricuspid and mitral valve stenosis. Sebab di soft tissue, the histologic of the valve kan. Kalau yang mitral and tricuspid itu dia little bit loose, dia kena ada chordae tendini, ada terikat to the ventricular wall. So dia jaranglah jadi stenosis. Kalau aortic and pulmonary valve memanglah dia kena kena rigid sikit, because pulmonary and aortic valve ni dia tak dia structure dia yang tricasp tu dia ada 3 valve. Kalau tak rigid ya dia tak akan boleh tutup dengan baik kan, tak tutup dengan betul, so kena rigid sikit. Tapi if too rigid, kaku sangat, dia jadi stenosis. Okay, itu ya. And then next lagi yang you should understand juga, depend on the severity of the stenosis. Kalau very mild, pasiennya still acyanotic, still pink. Tapi kalau very severe, kita sebut critical PS atau critical AS. What more kalau sampai atresia, maknanya tak boleh buka tutup, no function of the valve, ya jadi pasien jadi cyanosis. Ya. Oke, itu ya obstruction of the pulmonary and aortic valve. Lain-lain pasal ECG tadi, pasal X-ray, you belajar sendiri. Kalau dia ada stenosis akan nampak dilated pulmonary or aortic or aorta ya, pulmonary artery or aorta. Dan boleh juga right ventricular hypertrophy kalau 4PS atau left ventricular hypertrophy kalau 4AS. ECG pun boleh nampak ya. Oke, so paham pasal PS and AS ni? Apa-apa yang nak tanya sebelum kita discuss yang AS? Bukan AS pula, COA ya? Ada yang nak tanya tak? Okay, I will not call one by one lah, because most of you do not want to open your video. Saya pun tak tahu you all ada ke tak. It's okay lah. If you don't want to hear, it's okay. You want to learn, yeah, it's good for you. For me, alright. Mana presenter ni?
Yes, ada.
Okay, ya. For the COA, coba tunjuk gambar yang tadi, yang slide berapa, yang akhir-akhir je, yang manajemen je. Slide yang manajemen tu. COA, coaptation of aorta. Mana? Slow ke ni, internet?
Slow. Nampak?
Yang ada gambar tadi. Gambar management of COA tadi.
Gambar cervical.
Next. Management. Okay. Dah ini. Alright ya. So everybody, you look carefully this picture. Itu ya, structure of the coaptation of aorta tu. Dia ada narrowing of the aorta. You nampak tu kan, aortic arch there ya. Blood from left ventricle go to the ascending aorta, goes to the aortic arch. This one is normal aortic arch ya. From right to left, kita sebut left aortic arch, left sided, left direction aortic arch ya. Memang normally macam tu. From left ventricle dia cross ke kanan sikit, aorta tu sudah aortic valve you hear on the upper right, bukan ke left side ya. You hear the sound of the aortic valve tu on the upper right karena dia cross ya. Yang pulmonary valve pun terbalik juga, from the right ventricle dia cross to the left, upper left. Nah, so ini kita discuss aorta. Kenapa? Karena there is no narrowing of pulmonary artery, dia ada. Kita sebut usually narrow or small PA je, dia tak sampai critical sangat usually, unless kalau dia atresia. Jarang. Yang more significant is aortic arch ya. This one you tengok from right side, the arc to go to the left. Kita sebut left sided aortic arch. This one yang normal. Boleh juga ada yang terbalik ya. Kalau dia terbalik right sided aortic arch, cerita lain lagi. Kan we discuss yang left sided aortic arch, you tengok branches. There are 3 branches kan, ada 3 cabang dia ya. So yang first branch go to mana, Najimi? Nah, tadi 2 aja yang saya kena highlight to you all. Kena ingat-ingat, structure kena paham, dan hemodinamik kena paham. Structure-nya bagaimana? Ada branch tuh, ada cabang 3 biji yang naik, 3 tube, 3 arteri yang naik tuh. Bagaimana?
Brachiocephalic trunk. Right brachiocephalic trunk.
Right, ya, right subclavian atau brachiocephalic ya. Dia pergi to the right, yang lagi gerak tuh yang right subclavian lah, pergi ke right arm ya, and hand ya. The second one is go to cephalic kan, to the carotid artery. Dia akan ada 2 branches nanti kan, ada common carotid artery and branch right and left. Ya. And then yang third branch, yang nomor 3 adalah to the left subclavian, to the left hand and arms ya. So you tengok situ ada 3 kan. So most common of the narrowing will be there kan. You nampak kan, after the left subclavian, after the third branch. Tapi there is also possibility of the narrowing itu after the first branch. After the first or second dia sama aja, ke nanti efek consequences dia, findings dia ya. So akan two possibilities ya. Yang first, yang most common yang ini, after the third branch, masa dah descending aorta tuh dia akan narrowing. This one most common COA. Tapi another one yang possible is after the first branch, maknanya yang penting before the third branch ya. So findings will be different ya. So how do you diagnose COA is simple kan. The first of course the narrowing tu you will hear the murmur, but murmur tu usually difficult to recognize karena why? Because because the depend on the severity of the narrowing. Kalau severe you will hear very loud murmur, tapi kalau mild narrowing murmur may be very soft. And then location pun bukan, aorta is not on the anterior wall but near to the posterior wall, the back of the patient. Usually when you auscultate kan, you auscultate precordial kan, auscultate ke depan on the chest. So maknanya when you auscultate on the chest tu, the turbulence, the murmur of the COA usually very soft lah, tak dengar sangat. If the characteristic of the murmur tu similar with PDA, dia akan continuous murmur. Karena the flow of the aorta itu akan continuous kan, even systolic or diastolic dia akan terdengar sentiasa. Nah, if you are clever, masa you you hear very soft murmur on the anterior, you compare to the posterior wall, to the back of the patient, you akan hear clearer murmur, louder murmur. Tapi when you need to check the back of the patient, if you before auscultation, if you get the finding for the COA, apa yang spesifik is the radio femoral or radial delay. Ya. So itu yang penting when you do CVS examination, don't go straight to the chest, don't go directly to the precordial examination. It is even since initial pun it is important to do general observation and inspection, and then yang penting tuh hands examination, tengok di pulse, tengok di radio femoral and radio radial delay. So kalau the picture macam ni, if the narrowing tu is after the third branch yang most common ni, so which one do you get, radio radial or radio femoral delay? Senyap je semua.
Radio femoral.
Good, yeah. Most common will be radio femoral delay, yeah. Because it is similar lah between right and left radial artery. Right and left subclavian branch akan sama. Tapi yang after the narrowing, after the COA, yang goes to the inferior part of the body, yang go to the femoral artery, dia akan delay. Different if the COA is before the left subclavian branch too, because before the third branch, you will get the radio radial delay. Okay, and then another one, after you get radio radial or radio femoral delay itu easier to bukan confirm lah, to recognize COA-nya. You ask for limb BP, ya. So blood pressure, compare the blood pressure all 4 limbs, ya. Right, left arms, and then right and left legs. So maknanya kalau you get this kind of COA nih yang ada radio radial delay, there will be different blood pressure between upper and lower extremities. Which one will be higher? Najimi?
Yes, the upper is higher than lower.
Okay, good. Yeah. Because upper arm before the coaptation, before the narrowing, need higher pressure to pass the coaptation, to pass the narrowing part of the aorta. So akan higher BP on the upper extremities. Nah, kalau tadi yang radio radial delay, the narrowing to before the third branch, you will get higher BP on the right side compared to the left side. Okay, ya. So itulah, you need to compare all 4 limbs BP, right, left, upper, lower. So akan nampak lah dia COA dia kat mana. Higher pressure usually right and left juga lah. Tapi boleh je right to left tu tak sama. Beza dia kalau you only 1 or 2 mm mercury is not significant. Yang signifikan if more than 5 mm mercury. Okay. So this the simple thing to understand, ya. Ada lagi ya, kalau you nak more belajar tuh actually kita sebut preductal and postductal juga, because actually on the aortic arch tuh normally there will be ductus arterial source, tapi will close after birth. Yang preductal ya sama lah, preductal tuh yang on the right arm, postductal on the left arm and on the legs. Tapi itu apa? Not really related with coagulation of aorta, tapi sometimes kalau you nak belajar PDA, you need to know preductal and postductal juga. Nanti after this ada kan yang PDA. Okay, itu aja how you recognize the heart disease ya, this one the outflow tract obstruction ya. Itu aja yang penting. Lain-lain lagi macam interrupted aortic arch ya, you get similar finding, ada aortic atresia, pulmonary atresia, lain-lain tuh jarang ya. Ya possible juga, tapi usually patient in more severe situation lah. Kalau patient-patient yang AS, PS, COA ini boleh patient boleh stable and then can come to you in normal situation, maknanya can come to clinic ke outpatient setting. Kalau yang interrupted aortic arch, yang atresia pulmonary or aortic valve tuh kayak in critical situation, kita sebut critical congenital heart disease, patient pun akan need emergency management during neonatal. Usually dia ada besar pun dah ada post operation, post correction. Alright. Aduh, saya ada problem sikit ni. Tak apalah, you start because yang this phone ni low bat, nanti kalau I got disconnected, nanti I will record. Alright. Next. Mana? Yeah, thank you Najimi. Next presentation.
Okay, can everyone see my slide?
Yes.
All right. Okay, Assalamualaikum. My name is Alisa Ahmad Hafizal. And I'll be talking about acyanotic for today. And I'll be covering about acyanotic CHD. It's a class of a congenital heart defect, and it's usually makes up 68% the CHD is acyanotic. And in this situation, the blood is shunted from the left side of the heart to the right side of the heart, and most often it's due to a structural defect. And in acyanotic CHD, patients normally retain normal levels of the oxyhemoglobin saturation. So that's why they are known as acyanosis. But then after a long period of time, the patient with acyanotic heart defect, they can also show cyanosis due to insufficient oxygen in the blood. So as late kids instead of blue babies. Blue babies would be in cyanotic CHD. Okay, this is the outline of my presentation. Okay, I'll start with ventricular septal defect. So what is ventricular septal defect actually? Ventricular septal defect is when a condition where you have a hole or a defect in the septum that divides the ventricles, and this results in communication between the right and the left ventricles. And ventricle septum as a whole is a complex structure, and it can be divided into 4 components. The first component is the muscular septum, which is the largest component out of all. And second is the inlet, or known as the posterior septum, which comprises endocardial cushion tissue. And then thirdly, you have the subarterial, or known as supracrystal septum, which comprises conotruncal tissue. And lastly is the membranous septum, which is located below the aortic valve, and this is relatively small. So VSD occurs when one of these 4 components fail to develop normally. For the epidemiology, VSD makes up around 30% of the CHD, so it is the most common CHD. And among all of the VSDs that we have, perimembranous type is the most common. Okay, the etiology of the VSD. VSD can be caused by various causes, and one of the factors can be genetic factors, can be due to chromosomal and a single gene and polygenic inheritance. And it also can be associated with, for example, like fetal alcohol syndrome, Down syndrome, and other cardiac deformities. And second factor would be maternal factors can also lead to VSD, like maternal infection, for example, due to rubella or influenza or even febrile illness. And also maternal diabetes mellitus, and also if the mom has phenylketonuria during pregnancy. And it can also be caused by exposure to toxins or even as drug side effects. So for example, like substances like alcohol, marijuana, cocaine, and drugs like metronidazole and ibuprofen. Moving on to the types of VSD. As I said earlier, the most common type of VSD is the membranous, or call it perimembranous. This one is the one that lies beneath behind the flare of tricuspid. And membrane also divided into infracrystal, which is more common, or supercrystal, which is pretty rare. And then the second type of VSD is the muscular. This one is the VSD that is located in the mid portion, or you call it the apical region of the ventricle septum. And this one, the higher chance to close spontaneously. And muscular type of VSD can maybe be can be single or multiple, which is as a switchy septum. Okay, for the pathophysiology of the VSD is that as you guys can imagine, we have a hole right here, right? The ventricle septum. Cover and it goes to the right atrium, the right ventricle, either go to the lungs, proceed to the lungs, or it can go through the hole here. But then again, as we all know, our heart, the left and the right, the left has higher pressure compared to the right. So blood loves to flow from high pressure to low pressure. The deoxygenate from the right side of the heart, because you know it's in the low pressure system, so it will just proceed to the lungs. It will not, I mean, it's likely to go through the VSD. And then for the oxygenated blood that comes from the pulmonary veins, it goes into the left atrium and then flows into the left ventricle. And then because oxygenated blood is already in high pressure system, so obviously it will go to the right. So this is when you call it left to right shunt. And then you can observe that there will be increased in pulmonary blood flow, and as well as the increase in oxygen saturation in the right ventricle and pulmonary artery. Important unique thing to note is that as the blood flows through the VSD, through the hole here, that's when you can auscultate and hear the hollow systolic murmur because of the blood flowing through the VSD. Okay, over time, after a long period of increase in blood volume because of the left to right shunt just now that I've explained. So when on the right side, from here just now it goes there, right? So eventually on the right side, we have a lot of blood flowing, and then increase in the volume will then increase in the pulmonary pressure, and then it will lead to pulmonary hypertension. So because it has a lot of pressure here, it would then, the pressure here will then exceed the pressure on the left. So when the right-sided heart pressure is greater than the left, that's when the shunt will then switch. So just now, it was from left to right shunt. now it becomes right to left shunt. This switching of shunt is the one that we refer to as Meninges syndrome. So this is the after long term of left to right shunt, it can then reverse back. Okay. So when it reverses back, so right to left shunt, we have deoxygenated blood that goes into the left ventricle, and then this will go into the systemic circulation. So as I said earlier, eventually after a long period of time, we will have cyanotic patient eventually. All right. So for the clinical manifestation, for the small VSD, normally patient will be asymptomatic, but loud, harsh, and low systolic murmur. It's loud because it's a small defect. So like if you can imagine like a small defect, so it has like a higher resistance to pass through. So that's why it makes like a loud sound. And then it can also be by frail. Whereas for the large VSD, the moderate to large VSD normally results in pulmonary overcirculation, and this will lead to heart failure. So the pulmonary hypertension responsible for the cardinal signs of the congestive heart failure. So you can see that the patient comes with dyspnea, feeding difficulties, poor growth, failure to perfuse perspiration, recurrent pulmonary infection, tachycardia, cardiomegaly, and hepatomegaly. And also, you can also hear like a soft hollow systolic murmur. Why is it soft? Because it's a large defect, so larger diameter, so it will like passes through smoothly compared to the small defect just now. So you can also observe active precordium and heard, and then apical mid-diastolic murmur at the apex also can be heard. This is because there's an increase in blood flow across the mitral valve. So after the blood circulating through the lungs. You guys understand? It's like, you know, when you have a lot of blood flowing through the pulmonary artery just now that I said. So when it has a lot of blood flowing through the pulmonary artery, eventually it will come back to the heart, right? It will pass through the mitral valve. So when there's an increase in the blood flow through the mitral valve, that's when you can hear the mid-diastolic murmur. And then you can also observe splitting S2 and loud P2 due to the pulmonary hypertension, particularly to the because of the increase in pulmonary arterial pressure. All right. So moving on to the investigations, we will normally do chest X-ray, ECG, and also echocardiography. And this depends on the size of the VSD. For the small VSD, normally the chest X-ray and ECG would be normal, not much of significance. And whereas for the large VSD, you can see cardiomegaly, increasing pulmonary vascular markings, plethoric lung fields, and pulmonary edema because of increased in pulmonary blood flow. For the ECG, in large VSD ECG, you can see left ventricle hypertrophy. This is because of the volume overloading the left heart. And then you can also, if you see like an upright T wave on the ECG, that's one of the signs of pulmonary hypertension. And why do we do echocardiography? Because it helps to demonstrate the anatomy of the heart defect and then also to assess the hemodynamic effects. For the complications, the possible complications that can occur due to VSD is pulmonary hypertension, as I explained earlier, infective endocarditis, Meninges syndrome, heart failure, and recurrent pneumonia. For the treatment, normally, a third of the VSDs close spontaneously, but then if the ones that do not, they have different treatments depending on the size of the defect. Normally for the small defect, we don't really give treatment because they have like a high rate of spontaneous closure. But then there are treatment for subacute bacterial endocarditis prophylaxis. Also do yearly follow-up if the patient, to look for if patient have aortic valve prolapse or regurgitation. And surgical closure would be considered if the patient have prolapsed aortic valve. For the moderate size of the heart defect, if the patient have heart failure, then you you will give the anti-heart failure therapy such as diuretics, digoxin, captopril. You would also consider surgical closure if the heart failure is not being able to be controlled by the medical therapy, or if the patient have persistent cardiomegaly and also persistent increase in pulmonary arterial pressure, or when patient have aortic valve prolapse or regurgitation, or even infective endocarditis. So these are the factors that you would want to start consider surgical closure. For the large defects, normally doctors will do early primary surgical closure. This is because it helps to prevent permanent lung damage from the pulmonary hypertension and the increase in the pulmonary blood flow. More like a method for the large defect, known as ASD. Okay, ASD is a birth defect of the heart in which there's a hole in the septum that divides the atria. And it can occur in any portion of the atrial septum, be it secundum, primum, or sinus venosus. So it depends on which the embryonic septal structure has failed to develop normally. The prevalence ASD makes up around 10% of all of the CHD, and most of the ASD cases are isolated and sporadic, and but then some may be due to genetic syndrome, for example, like Holt-Oram syndrome. And important thing to note is that ASD is more common in females with the ratio of 2:1. Okay, types of ASD. ASD can be classified by its location. The most common, the one that makes up 80% of ASD altogether, is the ostium secundum. Ostium secundum is the fossa ovale, which is located in the middle atrial septum. This one normally happens from the arrested growth of the secundum septum. The second type is the ostium primum, which makes up around 20% of the ASD. And this is when you have the defect in the anterior inferior aspect of the septum. This one normally happens when the septum primum does not fuse properly. So they have like a hole around here. Is when the heart defect is located in the posterior aspect of the septum. So it can either be near the superior vena cava, sinus vena will be known as inferior sinus defect. It's almost similar. It's also about the left to right shunt. So as we here next to two atria together. So the blood, the oxygenated blood will just now. Then for the clinical manifestation,
Hilang ya Alisa ni. Hello? Ni ada siapa ni? Ashraf. Ashraf, unmute please.
Okay, yes.
Alisa ni hilang ke?
Rasa dia
Macam mana ni? Itulah. Apa? Who is the
oh my God, I'm
third
so
presenter
sorry,
siapa?
I got disconnected. Sorry.
Oh, okay.
Wait, okay, where did I stop just now?
Pathophysiology.
Did I get to finish it or do I have to go back?
I think you just start just now.
Oh, I just started. Oh my God. Okay, okay. All right. Okay, for the pathophysiology, is the same. Left to right shunt. Okay, you have the high pressure on the left side of the heart and then lower pressure on the right. So the oxygenated blood will then flow from the left to right because of the pressure difference. And then you can see higher oxygen saturation on the right side in the right ventricle or even pulmonary artery. It's similar concept to the VSD just now, but then different location of the heart defect. And then for the clinical manifestation, for ASD, mostly patients would be asymptomatic, even though they have large ASDs, and even if they have significant shunts, normally they would be asymptomatic. But then if they happen to be symptomatic, they would normally come with like recurrent pulmonary infections or failure to thrive. And then in adults, they would have arrhythmias in around 40 years old like that. And then you can see fixed and widely split S2. This one happens because of the right ventricle stroke volume being equal in both the expiration and inspiration. And then you can also hear systolic ejection murmur at the upper left sternal edge. This is due to the increase in the blood flowing across the pulmonary valve because of the left to right shunt. And then you can also palpate right ventricle impulse at the lower left sternal border. And for a larger shunt, you can hear mid-diastolic murmur at the lower left sternal border. And this is because of the increased in volume passing across the tricuspid valve. So that's why you can hear it, because of the increase in the blood flow. And then for the investigation, we do as per normal chest X-ray, ECG, and echocardiography. For the chest X-ray, you can see cardiomegaly with or without pulmonary plethora. You can see right-sided dilatation, right atrium enlargement, increase in pulmonary vascularity, and prominent pulmonary artery. And then for ECG, normally you can see right axis deviation due to the enlargement of the right ventricle. And then can also see partial or complete RBBB, which stands for right bundle branch block. This one, it means that there's a blockage of the electrical impulses to the right ventricle. And then echocardiography is just to hemodynamic measurements and also to visualize the size of the ASD. Complications, the possible complications would be Asperger syndrome and paroxysmal embolism. Management. Medical management is rarely indicated in ASD patients. But then if there's a significant shunt that's still present, even when the patient is already 3 years old, then you would do closure. For the secundum type of ASD, normally you would use closure device, transcatheter. For the type that is primum and sinus venosus type, normally you use surgical closure as the intervention. So this is how they use the closure device. And this is the surgical closure. All right, moving on to the patent ductus arteriosus, PDA. It's a condition in which there's a persistent communication between the descending thoracic aorta and the pulmonary artery that results from the failure of the normal physiologic closure. The prevalence is that excluding the premature infants, because premature infants with PDA is normally due to the prematurity themselves. But then PDA in full-term infants is usually associated with functional defect. So this prevalence is excluding the premature infants. So it represents around 10% of the CHD as a whole. And under PDA, 90% of PDA is isolated and 10% of PDA is associated with other congenital problems. For example, like congenital rubella syndrome. The etiology for PDA, it can be caused by genetic factors and also chromosomal abnormalities due to various reasons, such as rubella infection, fetal alcohol syndrome, maternal consumed of amphetamine or phenytoin. Can be due to prematurity, as I said earlier. This is maybe because of the immaturity of smooth muscle and the inability for the immature lung to clear circulatory prostaglandin. and can also be due to low birth weight, delivery at high altitude as well. Before to understand the pathophysiology, we need to know what happens during the fetal development and how it changes as the baby is born. During the fetal development, the ductus arteriosus is kept open by a high level of prostaglandin E2. Prostaglandin E2 is the vasodilator that is produced by the placenta and the ductus arteriosus itself. And at birth, as soon as the baby is born, oxygen level increases dramatically, and then the lung becomes the main source of oxygenated blood instead of the placenta. And soon after birth, the foramen ovale closes and the level of the prostaglandin E2 decreases. So these two factors will cause the ductus arteriosus to close off. And then the lung starts to release bradykinin. And this bradykinin is a small peptide that helps to constrict the smooth muscle wall of the ductus arteriosus. And it sort of like help the process along the way. Okay, within the first day of the baby being born, usually ductus arteriosus starts to like clamp shut. And within 3 weeks, it is completely closed off and it will become ligamentum arteriosum. And if the ductus arteriosus does not close, that's when the baby is left with PDA. Okay, so this is like the pathophysio of the PDA. So we have the PDA here. So again, the deoxygenated blood flows through the right atrium, right ventricle, and then goes into the pulmonary artery. So when the blood is here, like it can decide whether we want to go this way or this way to the lungs. But then again, due to pressure, blood flows from high pressure to low pressure, and left side has higher pressure. So the deoxygenated on the right will not go past through the PDA. It will just continue and keep going to the lungs. Whereas the oxygenated blood that comes from the lungs, it goes into the left atrium, left ventricle, and then goes into the aorta. And obviously it's already in the high pressure system, so it will go through the PDA and then goes into the lungs for a second unnecessary trip to the lungs again. Asym-Menger syndrome can occur, but then particularly for this one, as it goes through the PDA, the deoxygenated blood goes to the lower extremities. Why only lower extremities? Because for the upper extremities, normally they have their own arterial branches, which are more upstream from the PDA. So it's like further upwards. So the deoxygenated blood will not go there. So it'll just go to the lower extremities. So this is when you can see what you call it as differential cyanosis, because only the lower part of the body is cyanotic. All right, for the sign and symptoms, small PDA, asymptomatic. Large PDA can come with symptoms of heart failure due to the decrease in the pulmonary vascular resistance and also increase in pulmonary blood flow. And then you can also observe like a collapsing pulse, or known as white pulse pressure. This one is because of the blood runoff into the pulmonary circulation during diastolic period. And then you can hear like machine-like continuous or systolic murmur beneath the left clavicle. This one is because this one will continue into the diastole phase because the pulmonary artery pressure is lower than aortic pressure throughout the cardiac cycle. And for the larger shunts, you can hear mid-diastolic murmur at the apex and also hyperdynamic precordium. This is because there's an increase of the blood flowing across the mitral valve. And again, splitting S2 and P2 intensity, it depends on the pulmonary artery pressure, and the thrill may also be palpable. Investigation, PDA, we do chest x-ray and echocardiography. It's similar findings as the large VSD. And yeah, and normally small PDAs have normal chest x-ray and ECG. Complications, the possible complications that can come from PDA is pulmonary hypertension, infective endocarditis, Asym-Menger syndrome, heart failure, and recurrent pneumonia. For the treatment, okay, for treatment, spontaneous closure after a few weeks of age in an in a full-term infant is normally uncommon. But then again, for the moderate and large PDAs, they normally give indomethacin and diuretics, and also eventually will lead to closure as well. And based on KIDS protocol, most of the PDAs can be closed by using coil embolization or the PDA closure device, and also surgical ligation. So this is the picture of the closure of the PDA using the catheter and the coil embolization. And then this is the summary of all. Okay, so basically the pathophysiology is almost similar, but then they come with different signs and symptoms because the defects are in different places, and the management is also different because the defect is in different places. So just remember that these three conditions, they are normally left to right shunt, and they all can have like possibility to lead to Asperger syndrome. And yeah, I think that's all from me. Yeah. Is there any question?
Alyssa, I have a question.
Mhm.
So do you think the Eisenmenger syndrome is like one of the most common complication, or it's more common if, like, since most cases are asymptomatic, that's when it becomes common?
I think it becomes more common if like the child gets untreated. So like as they get older, the pulmonary vascularization, I mean, the right-sided heart failure gets even more overworked. So I think children will not present with Asperger syndrome just yet because it takes a long time to acquire that kind of syndrome, I think, yeah.
Alright, Ain tadi ya, good question, and Alisa pun dah jawab dengan betul ya. Actually, if untreated and then reach adulthood, the older the child can develop Eisenmenger. But the keyword is if untreated kan. You know that Malaysia has a very good actually number one or on the top of the healthcare service in the world. So what more, the cardiology service in Malaysia is very good. So very rare you will see Eisenmenger in Malaysia, yeah, because the patient will be treated well, and then even the intervention one usually will be done early. Okay, so but actually what will be the most common and earliest complication of the most of the heart disease tuh? Ada left to right side especially ya. Kalau right to left side dia ada banyak lagi problem ya. Cyanosis, hypercyanotic, lain-lain. Kalau yang left to right side macam ni, ASD, VSD, PDA ni, earliest and most common complication apa? Siapa? Alina?
Elisa,
Alicia, sorry.
I think it's pulmonary hypertension and heart failure.
Not really. The
Not really.
failure lah. It will be failure. To get heart failure, not necessarily the patient must have pulmonary hypertension. So the earliest and most common will be heart failure. Yeah, so failure symptom. In some of the patient with heart failure, some of the causes, part of the causes will be pulmonary hypertension. Tapi not all kan. So the most common heart failure. Tapi memang some of them will have pulmonary hypertension, but not all lah. Even most of them ya PA pressure of the pulmonary artery still normal. Tapi develop symptom of heart failure when the heart is simply pathophysiology, when the heart is fails to pump the blood, so akan congested lah. Masa ventricle right and or left ventricle tu dia fail to pump the blood, so the blood will be congested. Kalau left heart congestion jadilah respiratory distress, bypassal craps. Kalau right heart congestion will develop edema, hepatomegaly, increase GVP. Itu last week kita udah discuss kan. Siapa yang last week present? Coba tunjuk muka. Yang last week present siapa? Saya pun dah tak ingat dah.
Saya doktor, me.
Siapa ini nama ni? Suhaib ya.
Ya.
So, betul tak Suhaib?
Betul.
Or you have other explanation? Itulah. So macam tu ya. So actually tadi Alisa ni present banyak sangat. Actually yang heart failure part tu tak payah present banyak-banyak lah. Just present
Okay.
VST tu apa what's the findingsnya.
Okay.
Okay, any more question? Tak ada? So sekarang kita discuss macam tadi ya. Siapa? Alright. Nama
Regarding the hello. Okay. Alisa, regarding
ni.
yeah. Regarding the complication, why is it paradoxical embolism only in ASD but not in VSD?
I've read somewhere about that. Paradoxical embolism is in ASD because, for example, if we give a patient with DVT, right? DVT, so the embolus will then passes through the right atrium first. So when you have the ASD, then it will bring the embolus from the right side to the left side of the heart, and then it will go to systemic circulation that can go to the brain. So that's why they kind of highlight it for the ASD patient. You get me?
Even with Eisenmenger kan? Kalau right to left sun. Because normal ASD, VSD ni semua left to right sun. Tadi tak tengok your slide ni. Ini kan more further lagi yang uncommon complication lagi. Dia develop Eisenmenger, tak jadi right to left sun, boleh jadi emboli. Itulah more uncommon complication ya. Tapi kalau yang cyanotic heart disease, common je emboli, brain abscess. Okay ya. So ini lagi less common lah yang discuss yang common je.
Alright.
Okay. Alright. Soal lagi nak tanya?
I have a last question. So regarding
Tadi ya. Sorry.
I have a question regarding PDA. Do we rarely do ligation for the management and like more so do closure than ligation? Like because all embolization and do we do that more than the ligation?
I think they will do more of the PDA closure device because that one is less invasive compared to surgical ligation, I would say, because the catheter will be like they put the catheter from the femoral vein, if I'm not mistaken. So instead of like opening the entire heart, they would prefer to do the catheter, I think. Yeah.
Okay. Tadi apa? What's the question just now? I miss apa tadi?
Ain
Connection
asked.
tadi.
Ain asked normally do we do the embolization, core embolization, or prefer to do surgical ligation?
Embolization like what? Tadi yang ada embolism ke? Kalau for the heart defect itself.
Treatment PDA to close it. So
actually bukan not really embolization, kita sebut ligation ya. Ligation tu ya PDA ligation actually itu open heart surgery ya. And another one ni tadi yang Alisa sebut ya, transcatheter closure. So maknanya bring the device, bring the PDA coil or amplatzer tu, ductal occluder through the femoral vein. Yang itu yang the less invasive betul lah. So memang current management kita try to close kalau memang indicated to close PDA itu with this transcatheter closure karena less invasive, juga less side effect, less complication, and faster recovery. Ya. Tapi problem dia mahal sedikit lah. Tapi again in Malaysia with very good service, IJN tu will get very good financial support lah. Most lagi patient bayar pun sikit je. Alright, ya kalau yang open heart surgery, kita buat ligation ya, bukan embolization actually. Ya, open actually not really thoracotomy, open thoracotomy yang stenotomy ya. Kalau PD ligation dia only subclavian punya incision je, sikit je. Okay, Ain? Okay, any more question? Okay, so we discuss macam tadi ya. So very basic, how do you understand the acyanotic congenital heart disease, left to right shunt ya. So there is heart defect. Usually between interventricle kita sebut VSD, interatrium kita sebut ASD, atau di tempat persistent ductus kita sebut PDA ya. Persistent ductus kita sebut PDA ya. So this defect will lead to left to right shunt simply because higher pressure of the left heart compared to the right heart ya. Left ventricle pressure dia the highest. Your systolic blood pressure tu equals to left ventricular pressure ya. 120 kalau in adult ya. Okay, in right ventricle dia lower maybe 80 je ya. Because to pump the blood to systemic need higher pressure compared to kalau nak pump the blood to pulmonary to the lung. Okay, atrium pun juga sama ya. Right atrium is the lowest pressure sebab need to receive blood from the systemic. Kalau higher pressure nanti jadi congestion, jadi increase JVP, hepatomegaly, jadi heart failure ya. Pulmonary pressure dia tinggi sikit karena need pressure to send the blood to left ventricle as well. So jadilah kalau ada defect kat sana jadi left to right shunt. So the problem will not cyanosis patient ya. Patient akan still ping, but the problem will be satu murmur lah of course findings, and then second ya karena left shunting of the blood, overflow, jadilah dia hypertrophy and dilated jadi cardiomegaly and heart failure. Itulah common ya. So apa yang kita manage is how to prevent or treat heart failure, and then later ya VSD dulu. VSD ya, defect bocor on interventricular septum. So the flow of the blood will be in systolic phase. So after S1, after close of the mitral anterospit valve, the ventricles will pump the blood. Itu sampai ke second heart sound, sampailah close of the pulmonary and aortic valve. Holosystolic or pansystolic murmur. So kita sebutkan the characteristic of VSD is pansystolic murmur. Location of the defect tu usually lower left sternal edge. Actually sama with location of the tricuspid valve ya. But better you don't mention ya, kalau you nak describe the defect as VSD, better you don't mention of tricuspid area, better mention as lower left sternal edge. The murmur edge. Kalau you sebut the murmur atresia, nanti our station ke macam tu contoh. Because sama kalau ada patient with tricuspid regurgitation systolic murmur on tricuspid area or lower left sternal edge. So untuk bezakan ya itulah, kalau PSC you sebut je lower left sternal edge, kalau tricuspid regus on tricuspid area. Actually same ya, same characteristic, same location. Okay. It's simple ya. The most common 25% of the heart disease, congenital heart disease is VSD. Maknanya kalau the most paling you tak paham apa, you jumpa patient with heart disease dengan murmur paling tak paham, you guess ya VSD lah. You have 25% chance to correct compared to other heart disease yang lain dia lagi rare kan, be correct. Tapi then the structure hemodynamic tadi, kalau ada pansystolic murmur on the left sternal edge, itu. And then tadi, ya paham ya? And then the second ASD ya, Alisa apa ASD findings murmur apa? Coba sebut lagi.
Oh, ASD.
Mana Alisa hilang ke?
I'm here. Systolic ejection murmur.
Yang keluar. Alisa, oke, Alisa.
Yes.
Oke, apa?
Systolic ejection
Oh,
murmur.
diastolic. Systolic
Sorry?
murmur.
Yeah.
Oke. Location? Location kat mana?
Upper left sternal edge.
Upper left sternal edge. So, ingat tak tadi Najimi present? Kalau pulmonary stenosis murmur apa tadi?
Pulmonary stenosis murmur is ejection systolic murmur. Right?
On? Betul, ejection systolic betul? Sama?
On the lower left sternal edge.
Pulmonary. Sorry?
Ejection systolic murmur at the
Mana? Ya, ejection systolic murmur on mana, Alisa?
on lower left sternal edge. Wait.
Lower left pulmonary area kat mana?
Upper right sternal
Tadi
edge.
saya dah pernah upper right tu pulmonary ke aorta?
Sorry doctor, I can't remember the location.
Najimi tak keluar lagi, mana Najimi ni?
Yes. Pulmonary stenosis. Upper left sternal edge.
Itulah yang kena kan
Ejection systolic murmur.
upper left lah kan.
Oh, at the same
Sama
side.
kan. Location only location only so bukanlah maknanya sama kan. Pulmonary stenosis, ejection systolic murmur on upper left. And then ASD juga sama kan. Ejection systolic murmur on the upper left. So maknanya the pathophysiology of the murmur itu sama ke lain?
Almost the same.
Jawab je. Sama ke lain?
Almost the same. Sama.
Sorry?
Sama. The same.
Sama kan. So this is yang interesting about the ASD. Why don't you hear the murmur due to the left to right shunt? So ASD kan left to right shunt juga kan, from left atrium to right atrium. Tapi actually you don't hear the murmur due to left to right shunt tuh. Kalau VSD kan due to left to right shunt, due to turbulence from left ventricle to right ventricle. Tapi ASD blood flows from left atrium to right atrium usually not develop a sound, not develop a turbulence, not develop a murmur. Sebab the pressure difference is low actually. Maybe yang left atrium only 10, yang right atrium 0 kan tadi. So blood itu akan flow very slow lah. Tak akan very fast because the murmur itu the faster the blood flows velocity, the louder the murmur. And then second thing, the smaller the smaller the way. Kalau small VSD dia akan louder the murmur.
The louder.
Ya USD ini tak dengar murmur from left to right shunt, tapi dengar murmur from relative pulmonary stenosis kita sebut. Kalau PS kan memang betul kan, pulmonary valve dia kaku, so masa opening pulmonary valve, ejection systolic murmur, early systolic murmur. Tapi kalau ASD kan actually the pulmonary valve normal, tapi you hear the turbulence on pulmonary area. Kenapa? Due to the excessive blood flow tadi from left atrium to right atrium, blood comes to the right ventricle, excessive blood, dia darah banyak sangat, and then excessive blood goes to the pulmonary artery, goes to the narrow area of the pulmonary artery, dia jadi relatif PS kita sebut, jadi turbulence kat sana ya. So that's why it is similar finding, sama, suara sama ya. Yang PS memang betul ada stenosis, kalau ASD kita sebut relatif PS murmur. Tapi what's the difference is apa second finding of ASD, Alisa?
Mid diastolic murmur.
No.
You mean the
Not the
murmur?
murmur. Not the murmur. Yang lain, other findings.
Fixed and widely split S2 sound.
Yeah. Can you explain that? Kenapa ada split?
It's because the right ventricle. It's because of the right ventricle stroke volume. The stroke volume is equal during inspiration and expiration.
Macam ni ya tadi ya. So yang the keywords of the pathophysiology tadi, the excessive blood flow tadi. Jadi kan excessive blood flow from the right ventricle goes to the pulmonary artery ya. So you can hear turbulence relative PS. The second thing, due to excessive blood flow, the closure of the pulmonary valve compare the pulmonary to the aortic valve, dia jadi delayed or earlier?
Delay.
Mana? Bukan, delay lah kan? Because need more time to finish the blood kan? So you need more time to finish the blood from right ventricle. So closure of the pulmonary valve will be delayed. So you hear a split.
Splitting.
Kenapa kita sebut wide split itu ya? Because very clear satu. Dan fix yang tadi fix itu maknanya in both inspiration and expiration. Kenapa kita sebut fix? Because you can hear normal inspiratory split in children. Ya. So kalau normal children tak ada heart defect, tak ada heart disease, you suruh dia tarik napas dalam-dalam, inspiration, you can hear an inspiratory split of the second heart sound. Ya. So split of the second heart sound of the closure of the aortic and pulmonary valve. Kenapa can normal inspiration? Halo? Boleh
Yes, we can hear
Boleh
you.
dengar?
Boleh.
Okay, because in Inspiration, there will be increase intrathoracic pressure, will increase venous return, will increase blood flow study to the right atrium, to the right ventricle, and then go to the pulmonary artery. So jadilah dia delay only on inspiration kalau normal. Pak kalau ASD ini wide and fixed in both inspiration and expiration. Oke ya, paham ya? Ini yang ASD. And then last one is PDA with the machinery murmur. Kita sebut continuous. Ya. Machinery itu apa? Other term lah. Actually ya, to understand ya continuous. Kenapa continuous? Yang mana in both. Waalaikumsalam. In both systolic and diastolic. Ya. Because in aortic and pulmonary artery blood flow itu dia akan even systolic or diastolic dia akan always flows, the blood will always flows nah. So jadilah dia continuous even systolic or diastolic dua-dua ada suara, tapi memang usually louder on in systolic lah, because on systolic kan there will be higher pressure on the ventricular contraction. Okay, itu yang penting ya, very basic how to get the diagnosis of VSD, ASD, PDA. Lagi satu tadi, PDA usually have wide pulse pressure due to the left to right shunt. So mananya dia diastolic pressure of the systemic dia akan very low ya. Okay. Alright. So I think that's all yang for second presentation ya. It's simple ya, you understand how to diagnose dulu. Nanti macam lain-lain complication management you belajar sendiri-sendiri. Even you don't manage kan, even me pun after diagnose I will refer to cardiologist, refer to IJN. They will do lah the closure, transcatheter or heart surgery. Okay, alright. Okay, thank you Alisa. Next.
Okay, thank you,
Last
Doctor.
one. Dah nambah. Welcome.
Alright. Can you guys see my screen?
Yes. No, not yet.
Start.
Yeah, I can see it now.
Okay, alright.
Okay, Assalamualaikum warahmatullahi wabarakatuh. Adik to Dr. Taufiq and also my fellow friends. So ending our seminar today, I will present to you on regards of cyanotic congenital heart disease. So this is my outline for my presentation, starting from overview and ending with prognosis and complication of cyanotic congenital heart disease. So a little bit of introduction. So we must understand what is cyanosis. Cyanosis is a bluish cast or bluish discoloration to the skin or mucous membrane. There are two types of cyanosis, which is central, around the core, lips, and also tongue, and also peripheral, only at the extremities or fingers at the nail beds. And cyanosis is characterized by an arterial saturation less than 90%, and also the partial pressure of oxygen is less than 60 torr. So we must do hyperoxia test for the neonates who is cyanosed. The infant is placed in 100% oxygen with a head box or ventilator for 10 minutes. Neonates with cyanotic congenital heart disease usually do not have significantly raised arterial partial pressure of oxygen during this administration. So what is congenital heart disease? Congenital heart disease is a defect in the structure of the heart or blood vessels that is present at birth. It usually occurs in 8 per 1,000 births and approximately 2,000 cases per year. It is a wide spectrum of abnormalities from simple to complex lesion causing hemodynamic compromises and sometimes early death. It is the leading cause of all birth-related infant mortality worldwide. What is cyanotic congenital heart disease? It occurs when some of the systemic venous return crosses from the right side of the heart to the left side of the heart. instead of left to right, which means there will be a right to left shunt, and where the deoxygenated blood will circulate within the arterial system, and this will lead to a cyanotic appearance of the neonates. So congenital heart disease is divided into two, which is acyanotic congenital heart disease presented by Sister Alisa, and cyanotic congenital heart disease, which about 22% of all congenital heart disease. Please remember that cyanotic congenital heart disease is a right to left shunt, and there will be two etiological factors. Firstly, is defect with reduced in pulmonary blood flow, which are tetralogy of Fallot and also tricuspid atresia. And mixed blood flow is transposition of great arteries, total anomalous pulmonary venous restrictant, truncus arteriosus, hypoplastic left heart syndrome. So as clinician, we must understand 5T, which is the most common type of cyanotic congenital heart disease, starting from tetralogy of Fallot, transposition of great arteries, tricuspid atresia, total anomalous pulmonary venous restrictant, and truncus arteriosus. So why it is important for us to identify congenital cyanotic congenital heart disease? Because it is one of the neonatal emergencies and it needs immediate recognition, diagnosis, and proper treatment, and to avoid neonatal death. So firstly, I will explain about tetralogy of Fallot. Tetralogy of Fallot is the most common type of cyanotic congenital heart disease. Comprises about 5 to 10% of all congenital heart disease in a prevalence of 3 to 6 per 10,000 births. It is due to abnormal septation of truncus arteriosus into aorta and also pulmonary artery that occurs early in gestation, about 3 to 4 weeks. Although there is no definite cause as to why some babies develop tetralogy of Fallot in utero, but there are certain environmental and certain biological factors that increase the risk. Firstly, the neonate is male, on maternal PKU, diabetes, alcohol, genetics, and viral infection, especially rubella. So tetralogy of Fallot means, tetralogy means 4 of Fallot. Fallot in French means cardiac anomalies. So the 4 cardinal components or 4 deformities of the heart, firstly is the ventricular septal defect, which is usually large and cause the pressure between right ventricle and left ventricle to equalize. Pulmonary stenosis that cause right ventricular outflow obstruction, and the pulmonary valve is sometimes stenotic, dysplastic, and have small annulus. The displacement and overriding of the aorta, displacement because during the development, it caused the aorta to displace to the ventricular septal defect, and also the VSD caused the blood from the right ventricle to flow or shunt into the left ventricle. And lastly, the right ventricular hypertrophy, which is due to the pulmonary stenosis and also the ventricular septal defect. So this is another beautiful picture of tetralogy of Fallot. So the pathophysiology of tetralogy of Fallot, firstly, the blood coming from the systemic circulation enters the right atrium and also the right ventricle. And the outflow from the right ventricle is resisted by the pulmonary stenosis, where it causes the narrowing of the right ventricular outflow tract. And this will cause the blood, the deoxygenated blood cannot flow into the pulmonary circulation to be reoxygenated. Thus, the right ventricle with its myocyte will hypertrophize and try to flow the blood and pass the stenosis. And this will cause two things. Firstly is the ventricular septal defect will cause the shunting of blood from right ventricle to left ventricle, and also due to the shunting can cause the overriding of aorta, allowing the deoxygenated blood to distribute within the body. And this again causes cyanosis. So the clinical manifestation of tetralogy of Fallot, firstly, it again can cause cyanosis, which depends on the pulmonary stenosis and can easily observe at the central cyanosis, which is at the mouth, the tongue, and also the mucous membrane. Hypercyanotic or TED spells, I will explain later. In older children, there will be also clubbing and also dyspnea on insertion. And will be also similar to acyanotic, can have signs of congestive heart failure. Upon auscultation, we can also hear pulmonary stenosis murmur, which is the ejection systolic murmur on the upper left sternal edge, which usually initially abnormal finding as the infant is acyanotic. And as the degree of stenosis increase and the degree of the right to left shunting increase, the murmur gets softer and also shorter. And this indicates more hypoxia And also at the left sternal border, we can auscultate and hear single S2, again because of the delay closure of the pulmonary valve and also the aortic valve. And also we can see the right ventricular impulse at the left sternal border. Okay. So what is hypercyanotic TET spells? Hypercyanotic TET spells is an episode of severe hypoxia and cyanosis in a child with TOF, and most commonly start around 4 to 6 months of age, where there will be sudden onset or deepening of cyanosis, more bluish, and sudden onset of dyspnea, and sometimes have delirium and decrease in intensity of systolic murmur. The pathophysiology of TET spells, firstly, when the infant has do the action that needs a lot of energy or a lot of oxygen, which is feeding, defecation, exercise, or sometimes crying. In Tetralogy of Fallot, this will lower the systemic venous return and increase the resistance of the right ventricular obstruction tract. Thus, this will contribute to the right to left shunt through the ventricular septal defect. And again, the oxygen is lower because it bypass the pulmonary circulation, and this in the child will stimulate the respiratory center to produce hyperapnea, and sometimes can be life-threatening. And again, how does squatting resolve this cyanosis? By squatting, it squeezes the vessels and increase the systemic venous return, thus increase the peripheral vascular resistance. Thus, this will reverse the effect of the shunt, will reduce the right to left shunt, and there will be increase in the oxygen content. So investigation of the Tetralogy of Fallot. Firstly, we can do chest X-ray. We can identify a classical boot-shaped heart, and echocardiogram, which is a gold standard and definitive test, is that we can identify the right ventricular hypertrophy and the thick wall. We can see the ventricular septal defect, and also we can see the overriding of the aorta. Similarly, with the first presentation, there will be in ECG, there will be a right axis deviation and also indicates right ventricular hypertrophy pattern. For management of Tetralogy of Fallot, for the TET spells, we need to do the squatting because this maneuver help increase the venous return and increase the systemic venous return, systemic resistance, thus reducing the right to left shunting. Next is oxygen administration, is to reduce the hypoxia and cyanosis. Morphine is also important to reduce the respiratory drive, therefore also reduce hyperapnea. If severe and lack of response, IV propranolol, which is a beta blocker, is commonly used for TET spells, which it works by reducing the heart rate. And IV phenelphrin is to increase the systemic vascular resistance, again to reduce the right to left shunt. And IV bicarb is important to correct the FCOCs if present. For Tetralogy of Fallot, a surgical intervention must be made. Firstly is a definitive repair or complete surgical repair, VSD closure, where it involves the right ventricular obstruction tract stenosis resection or dilation or removal of the pulmonary stenosis, the pulmonary artery augmentation, and also the VSD patch closure. Depending on the degree of the pulmonary stenosis, the pulmonary valve either repaired or spared, and usually must not be performed younger than 3 months old, or older than 4 years old. And we must do modified Balloch-Taussig shunt. Balloch-Taussig shunt is important to mimic the PDA, patent ductus arteriosus, temporarily before doing the definitive repair, where there will be a shunting between subclavian artery and also the pulmonary artery. And lastly, we can do subacute bacterial endocarditis prophylaxis, is to avoid, again, bacterial endocarditis. We can give antibiotics such as amoxicillin or ampicillin and so on. So this is a complete surgical repair of the ST closure. You can see the widening of the pulmonary trunk and also the closure of the VST. The modified Balloch-Taussig shunt that must be performed before the definitive surgery, the connection between the subclavian artery and also the pulmonary artery. So the prognosis and complication of the Tetralogy of Fallot. Due to the risk of long-term complication, lifelong follow-up is also essential, where the prognosis is excellent, as more than 85% of children with surgically repaired pathology of Fallot now survive to adulthood. If failed to treat and left untreated, this will cause significant morbidity and also mortality, which includes polycythemia, acquired secondary polycythemia, severous abscess, stroke, infective endocarditis, congestive cardiac failure, and also death. Next is transposition of great artery. Transposition of great artery or TGA is the most common type. The common type, which is 5% of all congenital heart disease, there is approximately between 20 to 30 incidents per 100,000 live births, where the hallmark of transposition of great arteries is ventriculoarterial disorders, secondary to abnormalities of septation of truncus arteriosus. Again, there is no definitive cause of TGA, but there is environmental and also biological, similarly with the TOF, tragedy of Fallot. And the characteristic of TGA, where the aorta arises from the right ventricle, while the pulmonary artery will be arises from the left ventricle. And this anatomical configuration of this anomaly establish a potential fatal parallel circulation that result in deep hypoxemia from lack of mixing, which result lactic acidosis. So it is okay in TGA to have mixing of blood, which is due to this deformity, such as from arterial we can see pattern foramen oval, ASD, VSD, and lastly is PDA. So level of mixing can cause the survival of the child. Again, another beautiful picture here. So pathophysiology from the aorta arises from the right ventricle, and the pulmonary artery arises from the left ventricle. Aorta carries unoxygenated blood from the systemic circulation, whilst pulmonary artery carries oxygenated blood to the pulmonary circulation. That cause the deoxygenated blood to bypass the lung and the oxygenated blood to recirculate only in the pulmonary circulation, as code can be trapped in the pulmonary circulation. And an infant can survive if and associated with a defect. These three common anatomic sites for mixing of oxygenated and deoxygenated blood, which is the pattern foramen oval, ASD, VSD, and also PDA. And this will allow the baby's life to be sustained. For clinical manifestation, firstly, without lesion, TGA can happen without lesion, without any ASD, VSD, or PDA, can have profound hypoxia, can have cyanosis, rapid deterioration of all the system, and eventually can cause death in the first few hours, and can also can cause quiet tachypnea, a loud single S2, and also no murmur. In TGA with lesion, ASD, VSD, or PDA, it can cause again cyanosis, depend on the amount of mixing of deoxygenated blood and oxygenated blood, where the child with large VSD may have improved intracardiac mixing and less cyanosis compared to without lesion, and also can have quiet tachypnea, and so loud single S2, and also a loud VSD murmur on the lower left sternal border. Also in TGA, there will be heart failure symptoms, which if the TGA is not treated, can progress to congestive heart failure in the first 3 to 4 months of life, where there will be excessive sweating, slow weight gain, irritability, lethargy, and also rapid breathing. Also, in TGA with lesion, there will be acidosis, because as there is lack of oxygen going to the distal organs, cells respire anaerobically, producing lactate. And also investigation, similarly we do chest x-ray, we can identify an egg on the string appearance due to the narrow upper mediastinum over here, and there will be cardiomegaly and also increased pulmonary vascular markings. Echocardiogram, again, it is the gold standard and also definitive test, where it shows transposition of great arteries, the abnormal position of the aorta, and also the pulmonary arteries. And we can do ECG, which there will be right ventricular hypertrophy, similarly to TOF. For management of TGA, for simple TGA without any lesion or without any deformities, Firstly, we can supply the infant with prostaglandin E1, which again establish the patency of ductus arteriosus, which allow mixing of blood. And also we can do Rushkin procedure. It is a iatrogenic or self-made ESD using a balloon to temporarily treat and mix the blood between these two circulation, the deoxygenated and oxygenated blood. And lastly is arterial switch. This is the definitive treatment where the aorta is switched to the left ventricle and the pulmonary artery is changed to the right ventricle. And TGA with ventricular septal defect, it doesn't require intervention during the early neonatal period, but it may develop heart failure at 1 to 2 months of age. That we can do one-stage arterial switch operation like this and VSD closure within the 3 months of life of the infant. And lastly, TGA with VSD and also pulmonary stenosis, we can do ballot tossing shunt, which is the connection between the subclavian artery and also the pulmonary artery, and followed by restally repair at 4 to 6 years of age. So this is a Rushkin procedure where from the iliac vein, we can ascend upwards and go towards the inferior vena cava and pierce the arterial wall and make a self-made or iatrogenic ASD to allow the mixing of the blood and increase the possibility of the infant survival. This is restorative procedure where firstly we put a synthetic wall across the right atrium, where also we put a connection or anastomosis between the right atrium with the pulmonary arteries, which there will be inverse action of the heart chambers. And arterial switch, which is self-explanatory, where there will be change of the aorta to the left ventricle and the pulmonary artery to the right ventricle. And prognosis and complication of TGA. Prognosis depends on the complexity of the TGA and how it was surgically repaired. And post-surgical correction survival is approximately greater than 90% at 20 years of age. And if left untreated, several long-term consequences are recognized, which includes right ventricular hypertrophy, congestive cardiac failure, heart valve problem, arrhythmias, and also death. So this is my reference. Thank you. Any questions?
Okay, thank you, Amir. So okay lah. So save the best for last. So mananya yang this one Amir present ni, I don't think I need to clarify furthermore lah. Kalau you understand Amir present, you can easily get lah how to diagnose TOF, TGA. Dua je kan ya? TOF and TGA.
Yes, dua je. Yes.
Alright. So itulah yang the two common. Ada lagi lain ya. Usually yang cyanotic congenital heart disease tu kalau nak senang ingat 5 T's ya. TOF, TGA, ada lagi tricuspid atresia, ada lagi truncus arteriosus, ada lagi TAPVD ya. Lagi lain banyak lah, ada DORV, ada hypoplastic left heart syndrome, yang lagi satu lupa je. Ada banyak lah. Jadi tadi yang macam aortic atresia atau pulmonary atresia usually dia akan cyanotic lah. Epstein anomaly ya, so banyak lagi kan. So tapi itulah cyanotic ni usually less common compared to acyanotic, tapi kalau you jumpa kan simple senang kan dapat patient tu pasti cyanos kan. Biasanya cyanotic nampak bibir dia gelap, kuku pun gelap, and then clubbing fingers, itu senang ya nak nampak tu. And then problem dia cyanotic tu usually kompleks ya. Dia tak simple kan, macam ASD yang satu je kan defect, VSD only one defect, PDA only one defect juga ya. Simple. Cyanotic tu will be kompleks ya, banyak problem dia. TOF ada 4 anomalies kan. TGA must be must have shunt, must have VSD or PDA or ASD. So macam tu ya, kompleks. So memang problem dia kalau kita untuk diagnose confirm tu with echo, with catheter tu memang susah lah, kena cari betul-betul mana satu kan. Tapi for you as frontliner ni, for physical examination senang je, nampak patient biru, so you sebut je complex cyanotic heart disease. So kalau yang tadi yang PS and then coarctation aorta, AS, VSD, PDA, ASD, you should diagnose very clearly ini mana satu. Tapi kalau patient biru, actually for you is easier. Patient complex ni problem lah, banyak lah. Sebut je, it is complex cyanotic heart disease, selesai lah. Because you will not know the defect, which defect is it, and it is until you do echo. After echo, we will know this one TGA with VSD, for example, or this one DORV, this one pulmonary atresia with PDA usually. Okay, so senang actually complex cyanotic heart disease. Tapi the most common will be apa, Emir? Most common cyanotic apa? Mana satu?
Tetralogy of Fallot.
TOF is most common kan? So it will be
about 5 to 10.
Good if you can diagnose TOF clinically. TOF tu we can guess we can suspect clinically when we do physical examination. Kalau yang lain-lain kan kena buat echo dulu baru nampak kan. Kalau TOF ni with physical examination, we can bukan you should or you must maybe kalau you tak diagnose pun tak apalah. Tapi at least kan you know it is complex cyanotic heart disease. Tapi if you can diagnose TOF clinically with your physical examination, so good lah for you. So ada 4 findings kan. Apa je Emil?
4 findings of tetralogy of Fallot. There will be narrowing of the pulmonary valve, which is stenosis, and there will be thickening of the right ventricle where the myocyte hypertrophies, and there will be displacement of the aorta and also overriding of the aorta, and also the ventricular septal defect between the ventricles.
Yes. So TOF ni story by Fallow Louis Etienne Fallow 1888, saya masih ingat dia. When he described TOF tu. So ada novel about this TOF ni, about di Fallow ni. Ada lagi filem tak silapnya, one movie tapi saya tak sempat tengok. Nanti cari ada yang actually movie about TOF ni. Kalau you suka tengok movie or you suka baca novel, biar you dapat ilmu sikit, carilah filem about TOF ni. Okay, so basically due to the PS, dia akan try to pump harder kan right ventricle, jadi hypertrophy. Karena ada VSD jadi right to left shunt, and then aorta dia override to right. This simple how to understand Findings pun masa you buat CVS examination, so you should you must get PS tu tadi, murmur dia.
Murmur, pulmonary stenosis, murmur.
Apa Emil?
Which usually, pardon?
Apa?
Usually,
what is it?
For the pulmonary stenosis murmur, we can identify the ejection systolic murmur on the upper left sternal edge or sternal border. And first from the initial,
so when you ask
from the initial, there will be less pulmonary stenosis murmur, and then become softer and shorter as the VSD larger.
So when you auscultate, masa you cari murmur to diagnose TOF, you must get the PS murmur first, and then when you palpate, so when RVH, right ventricular hypertrophy, when you palpate, you can recognize apa?
Recognize the right ventricle.
Boleh dapat apa? Right ventricle. No, when you palpate,
Palpate, apa dia?
right ventricular hypertrophy. Palpate
Yes,
the
yes.
chest.
Dia,
Palpation.
cardiomegaly.
No. Apa yang you dapat? What sign that you get when you do chest palpation?
Cardiomegaly, we can palpate the heart, which is a nudge, especially on the right ventricles.
Yes. Apa yang the specific finding about RVH when you palpate on the left side, left parasternal?
I'm not sure, doctor.
Akan
Because
dapat left parasternal apa?
Heave.
I have a HIF, sorry. I have a HIF. Right,
HIF,
first,
yeah.
right, HIF.
Good. So you get left parasternal HIF due to RVH, and then last kali tadi lagi satu ya due to the boot shape heart tuh you get displace of the apex beat, but not really like other cardiomegalies ya. Kalau cardiomegaly yang enlarged heart, you will get apex beat to go to the lateral and downward kan, variate
Yes.
apex.
Yes.
But in TOF nih, due to the boot shape kita sebut lifted apex ya, displace to the left ya, tapi di apa namanya level dia sama SES4 or maybe higher, maybe SES3. Kita sebut lifted apex. So itu ya, if you get this findings ya, left parasternal heave and then lifted apex ya, displaced to the lateral but not downward, only boot shape heart ya, and then get PS murmur, you may give suspicion of diagnosis of TOF. Ya later again we need echo. Ya buat TOF, and then problem dia no heart failure ya. Kalau yang lain-lain tadi kan most likely heart failure kan dia problem dia. Kalau TOF ini dia due to the increasing cyanosis dia boleh jadi hypercyanotic spell ya. Yang tadi Emil explain kena buat squatting position and give propanolol, give morphine to dilate the stenosis. Okay. Alright ya, yang itu TOF. Last kali buat di TGA ya. TGA is transposition. So aorta not from left ventricle but from right ventricle, and PA from left ventricle ya. Tertukar ya, switch artery and then jadi paralel ya. So if simple TGA, patient will not survive because isolated circulation. Yang pulmonary, for example, from left ventricle goes to the artery, goes to the lung, pergi pulmonary vein, left atrium, left ventricle lagi. So pusing di situ. Yang sistemik pun right ventricle, aorta, vena cava, right atrium, balik lagi right ventricle. So isolated circulation, no communication between systemic and pulmonary circulation. So jadilah kalau simple TGA patient ya pass away. So need shunt ya, need VSD or need TGA, need VSD or ASD or PDA ya. So itu cerita TGA mas kompleks ya. Yang lain-lain pun sama lah, yang cyanotic ya usually need complex ya, needs other defect. Okay. So murmur pun masa you auscultate ya depend lah. Kalau dia ada VSD ya dengar VSD murmur, ada ASD ya ASD murmur, ada PDA ya PDA murmur ya. Alright, and tadi sedikit aja tadi dengar masa you present Raskin procedure itu dia iatrogenic apa?
Iatrogenic atrial defect. Atrial defect to cause mixing
ya.
of the blood.
Itu for simple TGA tadi ya. Yes. Yang saya cerita tadi kalau patient simple TGA masa baru lahir kan dia biru.
Yes.
And then distress. Kita diagnose cepat, kita sebut critical congenital heart disease kan, critical situation simple TGA. Sometimes we still have time lah, few hours kan. Kita patient nampak biru, we do echo cepat, bedside, and then nampak TGA with intact septum kita sebut. Dia tak ada defect tadi, tak
No
ada
connection.
tak ada sun.
Mixture of blood.
So no connection. So buat Ruskin. So it is emergency emergency intervention to help to do connection between pulmonary and systemic circulation buat iatrogenic ASD. This one so this one yang interesting about the TGA. Sometimes simple TGA yang intact septum tu kita boleh buat kalau buat diagnose cepat in a few hours, and then buat Ruskin procedure cepat, boleh selamat, boleh survive patient ya. Kalau saya kita sebut critical congenital kalau tak buat apa-apa ya patient pass away lah. Finish. Alright. Lain-lain nanti you all tengok balik, kalau you boleh dapat recording of the seminar masa Emir pisan, you dengar baik-baik lagi ya, supaya faham ya, atau as slides from Emir ya. Alright. So anything?
Doctor, we want to
Dah
ask
clear ya?
tomorrow.
Yes.
We want to ask regarding tomorrow's session.
Yes.
So, like, what should we prepare, and like, basically, what should we do for tomorrow?
Putus-putus kan?
We wanted to ask regarding tomorrow's session, tomorrow morning
Hello?
session. Hello.
Oh, yang ini, yang the class ya. Di case presentation. Ya, saya perlu connection sikit, I close my video. Ini yang Ain pun tak dengar. Nurul Ain. Kau Nurul Ain yang poor connection.
Can you hear me now?
Boleh.
So, untuk session esok dengan doktor ada nak suruh kita prepare apa-apa ke?
Ya, itulah. Okay, little bit briefing about the current update kan, because MCO you cannot come to campus. We postpone all the face to face kan. We can't doing online, but yesterday we had meeting with Prof Mazuki kan, and then tomorrow kan will be decided officially by the kuliah level. Nanti your posting ini patutnya kan 5 weeks kan. 9 weeks kan. So nanti yang block 1 ni buat 4 weeks online macam ni, and then so sekarang maknanya you are week 3 kan. You have another 1 week next week. And then after that you go to online block 2. You go to online ONG I think ya. So yang nanti and then yang 5 weeks remaining tu by end of December or January you can come to campus. So we will proceed with face to face. So nanti pun block 1 ni by next 2 weeks kami pun yang pediatric akan go for 4 weeks block 2 lah. 4 weeks block 2 and then online, and then harap in mid December yang block 2 tu can proceed with face to face lah. Semacam tu. So that's why online kan you ada minggu ini and next week kan. Seminar dah habis kan this week. So next kita aja next week dengan presentation. Even this week pun ada kan satu session online presentation per group kan. Yang esok tu group berapa? Ini.
Group 1, Doctor.
Group 1 kan main mentis ya. So I need to know you one by one lah, because my mentees lah. Kalau yang grup lain tak kisah lah, penting sangat. Yang grup one ni, I should monitor you one by one. So esok you cari, ya sekarang lah you cari atau patutnya sudah ada. You kontak je yang apa, yang your seniors lah, cari yang previous batch yang dah ada case write up, you pinjam lah atau you minta lah. Cari je any cases lah. Mereka kan dah because block 1 ni you tak boleh minta your batch kan. Yang kawan yang lain tak pernah present pediatric case lagi kan. So, you minta your seniors, cari case write up yang dah submit, any cases, cari yang simple je lah. Bawa pneumonia ke, bawa asma ke, bawa UTI ke, febrile seizure yang common case, yang you rasa banyak kat ward, and then you present. Esok 2 je lah, kalau boleh 2. Kalau tak ada pun 1 je lah. Cari mana-mana case write up, bawa a case, and then you present ya, seorang 1 lah. So maknanya esok 2 orang present. Ya by sampailah continue next week another 2, and then ada 5 weeks face to face, harap-harap at least ada all of you can present ya, kalau boleh 2 or 3 times present ya, per person ya. Dah paham?
Yang nak present tu macam mana?
Ya present lah ya, one or two of you know the case, asal you get the case, you present lah. How you present like long case lah. You present a case. Buat the history, chief complaint, SOP idea apa, and then post medical history, sama lah. And then pediatric history since birth, macam mana growth, diet, nutrition, growth macam mana, development macam mana, family social macam mana, vaccination macam mana, and then PED findings apa, and then diagnosis of the case tu apa, itu kita discuss kan. And then after diagnosis apa, differential diagnosis apa, investigation apa, management kita go through sikit je lah. Yang penting you tahu. Yang penting tu how to diagnose, what are the differentials, and then what investigation you should proceed. Dah faham?
Faham doktor. Thank you.
Doktor.
Jadilah. Yes.
Doktor, kita kena buat slide ke untuk esok untuk mudahkan?
Boleh. Kalau you dah ada biasa kan, you try to get file kan from your seniors tu, yang sekarang year 4 tu. You boleh buat slide. Kalau you present orally pun boleh. Verbal presentation, oral presentation tak apa. Tapi kalau ada slide kan senang nak nampak ya. So we discuss a real case lah, even though you don't know the case karena you tak tengok the patient, but at least we know the the approach lah, the flow, how to diagnose, what are the differentials, nak fikir apa, and then how to investigate. Alright, dengue boleh, dengue kan ramai je, cari je yang simple, and then every session you must present different cases, jangan asyik pneumonia je semua, tak belajar banyak. It is your own, pentingnya in clinical teaching tu experience kan. Kalau you present only same thing, you don't get much experience. If you present different problems, you have more experience. Okay? Dah, alright?
Doktor, one more question.
Yes.
Untuk esok, hanya subgroup 1 sahaja yang join session esok untuk BST, untuk long case presentation. Macam tu.
Okay, this is benefit of online session ya. Kalau group lain free, it is open for you to join. Karena cukup je the room tu, meeting room yang boleh Zoom. Kalau Zoom boleh pakai 100, Google Meet boleh 150. Yang posting lain pun nak ikut boleh lah. Sesiapa medical student nak ikut pun boleh. Janji UIA lah. Jangan student UM pula nak join. So apa? You have opportunity to get more more knowledge, more experience how to about the disease, about the clinical cases, clinical scenarios. So kalau yang lain free boleh, tapi kalau ada concurrent kelas ya bagi saya yang grup yang lain present dengan lecturer lain tak apa. Kalau yang grup lain free ya join je. So akan nampak lah yang malas, yang kat rumah tak buat apa, tak belajar. So kalau yang rajin join, rajin belajar akan nampak ya. Alright.
Sounds good, Doctor. Thank you.
Alright. Okay, so with that we close with us speaking for answer. Subhanallah. Okay, so yang group 1 or maybe the rest boleh join esok ya. We start ikut di the link, boleh Zoom, boleh Gmeet atau yang lain pun. And then if you can standby by 9 because sometimes esok Kamis kan. Sometimes I can finish early. Di round by 9 we can start the presentation. Okay, alright. Dah ya. Okay, thank you all. Assalamualaikum.
Thank you, Doctor.
Thank you, Doctor.
Thank you, Doctor.